speaker is Pratiksha Krishnatra, and moderator is Dr. Devika Barua. Dr. Devika Barua is ENT consultant at Nightingale Hospital and also visiting consultant, ENT consultant at Pratiksha Hospital. And her area of special interest is voice disorder and phonosurgery. Over to you, Devika.
Okay. Thank you, Anjana ma'am. Today we are here to discuss about Dysarthria, a basic clinical approach. Ms. Pratiksha will deliver this talk, and she is a bachelor and master's degree in speech and language pathology from All India Institute of Speech and Hearing, Mysore. Dysarthria is actually an imperfect articulation in speech, and it's symptomatic of a group of disorder relating to strength, speed, coordination, which involves brain and nerves, as well as musculatures of the mouth, larynx, and respiratory system. This is just a simple explanation, and we learn in detail from Ms. Pratiksha. You can start your talk. And she is now associated with Pratidhwani and also visits Pratiksha Hospital.
Thank you so much, ma'am, for the introduction. I would like to do the sharing, and thank you, Pratiksha Academics, for giving me this opportunity to share some of the knowledge, like just have a discussion. I'm pretty sure almost all of us know about Dysarthria already. We'll just have a basic wrap up of the whole this disorder. And so moving on with this Dysarthria. Okay, so when we say Dysarthria, already Devika ma'am explained about Dysarthria, that it is basically a problem in the musculature. So we will talk about the clinical approach, what we are going to do or what we should do and why does it happen. We are not going to say about all the neurological things today, but we will mostly talk about the speech motor control today. So we all know speaking is a very highly skilled motor behavior. It needs a coordination of all the senses and the sensory input of the body, the sensory output, the effector muscles, and then the motor neurons. And it will go and put all the information to the respiratory system, laryngeal system, orofacial system, and hence after everything gets activated, we can have an output of speech. So Dysarthria is basically a motor speech disorder. Motor speech disorder as in like the problem with the motor neurons, like lower motor neurons, upper motor neurons, or maybe some problem in the substantia nigra, basal ganglia, anywhere, any part of the brain, it might give us any kind of a motor issue. And that helps, like that's the problem. When there is a problem in the motor neurons, then the commands or the information that comes to our face or the larynx or any of the part, the neural firing, that is in a heaved situation, and hence the speech or the sounds doesn't come up in a proper way. So Dysarthria results from the weakness, paralysis, and discoordination, and also primary and secondary sensory deprivation of the musculature. Also, if there is an alternation in the tone of the speech musculature, and all these weakness or paralysis are due to the neurogenic etiologies. So before moving on to know what is the neurogenic origin or whatever, we are not going to discuss much on it. But what we want to see today is how the speech motor control happens, or how the motor neurons or how the motor nerves gives us speech, or how we come up with speech. So what happens in our brain, we actually, whenever we start talking or whenever we want to say out something, there are many theories which says how we speak. So I have taken Mackey's theory. This is one of the very famous theory given in 1970. It says that we have a buffer system, and that buffer system, what it does, I'll be explaining each and everything in the next slide. So I'll just initially say it out. Like we have a buffer system. That buffer system gives each and every sound. Okay, so this buffer system, let's see what is this buffer system. Suppose we take the word speech. So when we take the word speech, how the word speech will be buffered in our brain. So what happened when we have a derivations, like we have a drive to speech, that will be initiated by the limbic system and especially the frontal lobe. So that will be initiated by the frontal lobe, and then we will say, okay, fine, I want to say this word speech. So now what happens? So for the word speech, the brain will now find out, okay, what are sounds I have to take for the sound speech. So that is the buffering. It's like how we have a buffering when the internet is slow, so we keep buffering, like, we have to find out this word, like priming. So all the related sounds for speech, like p, s, t, d, l, k, all these sounds, these are related to somewhere of the speech. So my brain will now find out, okay, these are the sounds I need to say the word speech. So that's happened in the buffering stage. After the buffering stage, what happens is the contextual constraints and encoding. Okay, so now this buffering stage actually now gives us the phoneme. Phoneme means the sounds, the smallest sounds which we see are called as phoneme. So this phoneme, our brain will find out these sounds, and our brain will now keep all the sounds in one part. Now what will happen? We will have a contextual constraints coder. Now what will this contextual constraints coder will do? So now contextual constraints coder means now brain will find out, okay, I have something very similar thing, speech, and this is the context, means this is the time, this is the meaning I have to say the word speech. Okay, so this is the sound speech. Okay, so now what I have to do, now I have to put one after another to make the sound speech. So what will be the first one? First will be sir, then will be per, then will be e and ch. So P, E, ch. So there are 4 sounds, and now my brain have synchronizedly made it into 4 categories, like as, per, e, ch. So now after doing this, now contextual constraints have done this kind of encoding. Now what will happen? We have a scanner and a unidirectional booster. So this is the scanner and unidirectional boost. So now what they will do, they will now go to the auditory part of our brain, and then they will find out the rhythm. Out of that rhythm, they will say what is the rate of each and every sound I have to say. Like for speech, I have to make this kind of rate. 1, 2, 3, 4. So this is the rate I have to make the sound in. So the scanner is doing this work. Now, this whole part, like buffering, then encoding and scanning, these 3 parts come under the planning of a sound. So when we talk, we actually have 2 parts. One is planning and another is programming. So when the planning happens, this is the planning happening, and planning always happens in the higher part of the brain. Okay, and then after this, we come up with the programming part. So now they have done their like they have found out, okay, each I have to give in this rate, I have to say in this rhythm. So now they will fire the neurons, the motor neurons will fire all this neural firing will come to the musculature, to the lungs, to the vocal fold. Now for that, we will have okay, so now the motor commands came to the muscle. So from here comes the programming part. So now the programming is happening. So when the programming is happening, so in the programming, suppose the word sir, for the word sir in respiratory system, we have to exhale air. In the laryngeal system, for the vocal fold, we have to have an open vocal fold. It's so the opening of the vocal fold will happen. For the articulatory system, we have to have a closed philophrynggeal port and a constriction in our sound, or the constriction in our tongue and lips, and hence we can make the word this sound. Similarly goes to the word per. Again for per, respiratory system will give a air out. There will be again per. For per, we have to initially give an open vocal fold, and then it will have a adduction. Initially it will be abduction, then it will be adduction, and then in the articulatory system it will again have a closed vocal cord. So this is how we are programming our sounds, and we are giving as an output. Now for people with dysarthria, when the motor commands or the motor problem is a problem, like motor neurons are a problem, the problem comes up in this programming, not the planning. Whereas in apraxia, the problem is in planning. And in stammering and all also, the problem is mainly in the last of the planning and somewhat of the programming. So these are the problems of all motor neurons issue. But what today we are going to see is more of the problem in the programming part. So so basically with that, we have different types of dysarthrias. One is spastic dysarthria, that is when we have a lesion in the upper motor neuron. Ataxic dysarthria, when we have lesion in the cerebellum. Hypokinetic dysarthria, when we have the lesion in the substantia nigra. The hyperkinetic dysarthria we see when there is an issue in the basal ganglia or the extrapyramidal pathways, and flaccid dysarthria when we see it in the lower motor neurons when it is affected. And mixed dysarthria is generally, a lot of time we actually see mixed dysarthria where a lot of these issues will be there, especially in cerebral palsy and all. So especially in cerebral palsy and this kind of issues, we see more dysarthria because the motor neurons affected is in a very higher form, or it's in a very extended way. So generally mixed dysarthrias are seen in such cases. But a lot of time what happens, we see our children like they will come up with no proper history of any motor lesion, or they will not come up with any history of trauma or anything, but still after a point of time, or maybe after 2 years, they will even start speaking late. And after 2 years, 3 years, when they start up with speech, we see a very slurred and laborious speech. And then we find out that, yeah, there are a lot of dysarthric components in the children. And also a very interesting thing, what we have been seeing recently in our practice, children with hearing loss, they are coming up with a lot of problem with motor planning and motor programming. So that was earlier we were thinking like, how is it possible? So maybe after this thing, like when we saw this motor speech control, I think we can actually correlate why children with hearing loss have problem in articulations, and also in a lot of children comes up with apraxia. So I just want to put one video here. The child, he has a spastic dysarthria, but he has a laborious speech. But what's the problem he is facing is when he says the plosive sounds are pa, ba, ma, all these kinds of sounds are called plosive sounds. So he cannot give that plosive sounds. So his basic problem is in his laryngeal function and also in the bilabial functions, like moving his both the lips. Itu ki color? Blue. Ball. Ball. Bye bye. Bye bye. So here he is speaking. He don't have any problem in speaking. He will make all the intonations properly. He will say everything. But when we ask him to say pa, ba, ma, but he's not apraxic again. He is not apraxic. But it looks like apraxia, right? Like when we're asking him to say pa, ba, ma, but he's still not able to follow the words in command. So this is not exactly apraxia. This is dysarthria only. Here the problem is coming in his programming of his bilabials or the lip structures. So another So another case, she is 7 years old. She has flaccid dysarthria. This is just the speech I wanted to make you hear how the flaccid dysarthria speech.
What is your name? Sanika. वापस बोलो. My name is Sanika. Okay. आप कौन सी क्लास में हो? मैं चिकू हूँ. नहीं, आप कौन सी क्लास में हो? चिकू. नहीं, KG2 में. Or
so did you hear when the mother said KG2, she said JK2. So this kind of word transition, like KG, she cannot say KG, but she has a difficulty in synchronizing the words. Like instead of KG, she will say JK. So a lot of time, this kind of issues we see in children of dysarthria because they have difficulty in synchronization of the sounds even. Like what kind of sound they will put initially or what kind of sound they will put later on. Okay, so that's how we see a lot of time children with dysarthrias. So now if we see the diagnostic formulation, what kind of symptoms we need to see as dysarthric speech. Maybe if we see slurred speech, of course, also they are a lot of time accompanied with speech delay. They will have misarticulation, this coordination in speech will be there, their intonation will be not proper, and also they will have a nasalization in speech. Now, one thing we just wanted to share, like why there we see dysarthria and apraxia in children with hearing loss. There may be probable 3 factors. One is in the buffering system. See, again, what happens, the buffering system, what I spoke earlier, like when our brain buffers the sounds, like what are sounds I have to pick up, because that buffering system comes as some kind of representation of sounds or some kind of representation of the linguist means like whatever sounds we say, all these sounds are generally kept as some of the symbol in our brain. So when we hear a particular sound, we always keep that sound as some symbol with some rhythm, with some rate, and with some intonation. So rhythm, range, and intonation, all these 3 are the category of the temporal part of the brain. Those are the temporal aesthetics of the sound. So now if a child cannot hear, they won't have the temporal part of the particular sound. So temporal means that the rhythmic part or the rate part. So when they cannot have a rhythmic part or the rate parts, hence they cannot form any kind of representation of the sound. So they cannot, since they didn't have a long time of temporal or representation of its sound, what happens to them? They cannot form any kind of representation. Maybe after maturation of the brain, again forming or again giving a particular representation of its sound becomes very difficult. And hence what happens for them, once we put them hearing aid or once they comes up with a cochlear implant, what happens to them? Suddenly they start hearing the sound, but for them, making that representation itself becomes a big task. And after that, what happens to them? They cannot come up with those sounds. They don't know where to buffer the sounds or when to put the sounds. So if we say Papa, there some of the children come like that way even comes. So a lot of issues comes up. So that's what we've been seeing. Now again, temporal difficulty, hence scanning of the sound. Again, yeah, temporal difficulty will be there, and that's why they cannot scan. They cannot know what is the rhythm they have to put. So they will always, we will see a lot of misarticulation, or just now how they, like for suppose the word spoon, they will say un, or they will just make the rhythm or they will just make the intonation, but they will not say the sound properly. That will be there. Again, one more thing is there, unused speech musculature. Of course, if they're not speaking, a lot of time what happens, their motor control of the speech musculature become diminished or it decreases, and hence they have difficulty as a dysarthric, or they have difficulty in pronunciations and misarticulation. I have one video of a child. I'll try to share with this. It's not playing from here. This is the child. I'll just play this video. He has been asked to blow. He don't have apraxia. He don't have any issues as such, because we did an apraxia battery also. He don't have apraxia, but he is a late implantee. He has been implanted with a cochlear implant at the age of 4.5 years. 4.5 years. At the age of 5 years. Now he is 5.5 years. So for him, Ako. Ako. Bota, aru urai dia. Ura nai no? Eta urise tu. Etu eta iman durat ahise sa. Eta iman dur ahise. Wow, good. Once more. So basically, what happened here is the child was asked to blow. He blows. If we just suddenly give him, if we suddenly give him some hot cup of water, he will be like, okay, foo. He will do foo. He will know that to do. But that looks like more of apraxia. What happens in apraxia is like they involuntarily do the things, but when we ask them to do, they cannot do. But for this child, he don't have apraxia. Whenever we are asking him to do all the kind of oral movements, he's doing. But when it's coming like, you have to blow, that's where he is having difficulty. Now he cannot blow because he don't know how to use that speech musculature. So maybe they at that point, what's happening there is like the problem is more of at the programming. They have planned, the brain has planned, like, you have to give this much of air pressure, you have to give this much of air control. But now when he is supposed to use it, because he wasn't using it since so long, the parents also never make him do all these activities before. But again, not every children have problem in this vegetative sounds. Like for this boy, which I have shown you just now, if we ask him to say pa, 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 he will say, he will know that he has to move his lips, but he cannot come up with the proper sounds because his vocal fold closure, the vocal abduction, adduction, that doesn't take in place. That's not synchronized. So it's like he's just making the lip movements. Along with that, for pa, we have to have a vocal fold abduction and adduction. But for him, it's not synchronizing. He is only doing the lip movements, and hence this kind of issues are there. Okay. So the management comes. So in management, we have to, of course, work in each and every subsystems. Basically, all the subsystems are affected in dysarthria. The respiratory system we have to see, the resonatory system, the phonatory system, the articulatory system, the prosodic system. One of the very useful this thing is oral placement therapy works very well with children with dysarthria. Then non-speech oromotor exercises. We generally see a lot of therapy centers does non-speech oromotor exercises. This is a very big controversy still now. A lot of people say that yes, non-speech oromotor exercises helps a child in speaking. Another school of thought says it doesn't help. So it's a open thing. If somebody wants to practice it, they can practice. If somebody doesn't want to, personally, I also don't feel non-speech oromotor exercises actually helps much. But then a lot of people says it does help. So if some parents comes and tell me, please do this for me, then I generally do that. So with this, I would like to conclude my talk. Thank you so much. There is a slide if anybody wants to go through what are the type of dysarthria and what are the things we see. Thank you so much.
Okay. Thank you, Pratismita, for a nice presentation. Just I wanted to know the last part in the management, you said oral placement therapy. So what do you do basically in there? So if you can explain in a few lines.
Yeah, ma'am, actually oral placement therapy is more of it's also work in that condition where how I just say that non-speech sounds where we work, but it more of it works with the blowing and vegetative skills. We work more on the vegetative skills, and hence we have the massage and all, when we give massage to the musculatures for more of to have a better tonicity in the muscles, and also movement of the tongue. This OPT generally helps in swallowing also. It helps in dysarthrics. It helps in children with Down syndrome. It also helps in children with normal misarticulation. It's a certified course actually, OPT. If we are supposed to be an OPT certified therapist, after our bachelor's and master's, we are supposed to do oral placement therapy as a certified course. Okay.
So a lot of the patients with dysarthria, they also have a swallowing issue.
Yes, ma'am.
I feel with dysarthria in neurological causes. So you have to do therapy for both together?
Yes, ma'am. Yes, ma'am. That always goes hand in hand. So also we have to see, because a lot of time it's not only dysarthria, it's the language issues will be there. Dysarthria is mainly the speech part. Language issue will be there. The child will be delayed language, so the child will not speak for a longer time. Then swallowing issue. So all these three parts we have to work on. The cognition also, some of the children's cognition is also affected a lot of time. So we have to work in cognition also. So language, cognition, swallowing, and speech. All the four part we have to work.
Okay. So I understand because you work mostly with the children. So the presentation is also focused on the children mostly. Yes. But I wanted to know about this. In Parkinsonism is also a type of dysarthria. It's a hypokinetic dysarthria. So do you have any therapy program for them that can help them? Or we all know it's a slowly progressive disease, and as ENT consultants, we often encounter those patients. So we also do not know what to advise them.
Yes.
And
Ma'am, actually for Parkinson's, we have to work exactly like on all the subsystems, like on the respiratory, oromotor, articulatory, phonatory. We have to work on that, and along with that, we are supposed to work on the voice, especially with LSVT, Silverman technique. We have to use.
Okay.
So these two things are very important, especially this dysarthric, like how I have said now, the subsystems. Like all the Parkinson's I have been seeing, and I also deal with few of the adult cases. So those, they generally seem to have a lot of benefits with this therapy plan, rather than only OPT or anything.
Okay. Thank you. Thank you so much. If anybody wants to ask any question, they can ask Ms. Pratishmita, or any comments from Vishwas sir. I can see if he can comment. He is more experienced in this matter.
Pratishmita was talking mainly for the children.
Yes,
but,
sir.
What I think she has not talked about the adult. There is lots of adult population.
Yeah, I just asked one query, sir. You can also go ahead, give us some insights.
Motor neuron disease patients do come with dysarthria, no?
Yes,
there can be lower motor neuron disorder, upper motor neuron disorder. There can be flaccidity of the tongue. There can be spasticity of the tongue. There will be spasticity of the whole system, you know. Then, basically, when you work with the subsystem, I also don't believe that only oromotor exercise works. Oromotor exercise with speech sounds, that works. And I am on that thought of school, It is not that simple oromotor exercise that works. It is along with the speech sounds production, that works. Even if the programming is a problem, but the main system, whole subsystems are affected. So whole subsystem has to be worked, phonation, respiration, phonation, resonation, articulation, all system has to work simultaneously, Then only the system starts working, and it works both for the speech and swallowing, If you do swallowing only speech, all the oromotor exercise along with the speech subsystem, it works for the swallowing as well as for the speech,
Yes.
So I think this is very important that we work for the whole subsystem along with the speech sounds, and that works wonderfully.
Okay. Thank you, sir. Any other questions? I think Dr. Priyam has had one query and she has replied. Pratishmita also replied, but still I'll just read out. It's an excellent presentation. What exercise can we do to improve the respiration part? Does it involve EMST? Can you explain that a bit, Pratishmita?
Yes, EMST basically involves the working on the expiratory muscles. So it's a small instrument that have to be used for increasing the expiratory muscles, and that actually in turn helps in swallowing. It helps in the pharyngeal, and then also it helps with the speech musculatures. So that can be used in dysarthria, and even that can be used for Parkinson's also. In fact, it can be used in aphasias. So for any kind of adult cases, we can, like any kind of adult cases with weakness, or motor weakness, or breathing weakness, or they are not able to have a proper respiratory support, that EMST can be used.
And one thing, this patient has most of a clavicular breathing, and that clavicular breathing has to be changed to a diaphragmatic breathing and abdominal breathing. That is very important.
Yes.
Because, they use the clavicles to use for respiration purpose, and that has to be changed, and this is to be transferred to respiratory as well as for the your abdominal and diaphragmatic breathing, and that works good, that gives you more reserve volume of air.
Yes, because chest is the powerhouse of the voice. That gives us power. If the person is breathing by clavicular breathing, the short breathing, that will not make the voice perfect or loud.
Their lung system is also affected. They always try to use clavicular breathing or short breathing. So that has to be changed. That whole breathing pattern has to be changed.
Mhm. Okay, another message. SP Fukansar is commenting about nice presentation, but difficult to absorb. So dysarthria is a vast subject. I also feel that. So she has just touched upon the basics. So any disease specific, maybe we can have presentation, then that will be a different part. Because dysarthria itself has, as she explains, six variations, 6 parts. That 6 parts has different diseases under them. Even vocal fold palsy is also comes under dysarthria. That's lower motor.
Also,
yeah, flaccid. And also after stroke or CVA patients and losing their voice, that is also dysarthria. So there are.
Today, I just tell you one
Yes.
point. Today
Yes,
I
sir.
have seen a patient, the patient is 12 years of age. The patient was having hyperbilirubinemia at the birth. She has a blood transfusion, and they did not consulted with anybody till 12 years. Today they have come, and I found that the patient is having dysarthria along with hearing loss. And
Okay.
it's a moderately severe hearing loss. The child is not using hearing aid from the beginning, and along with that, she has dysarthria. So these things, these are very important things. Hearing loss with dysarthria.
Okay. Okay, sir. So that person's need will be first hearing aid, then
Well, the
maybe
patient should. I am telling them that they wanted a speech therapy. So I said, what speech therapy?
Okay.
If the child doesn't hear, what is a speech
Yes,
therapy?
yes.
The child must hear, then only speech therapy will start, and it will work good. The patient has good vocabulary of speech. She's attending school at 6th standard, and teacher says that she doesn't understand, and they are not ready to use a hearing aid.
Okay. Okay, sir. And there is one more question from Priyam. I think is there any role of sensory or thermal stimulation in dysarthria?
Actually, if dysarthria, purely it is dysarthria without any sensory input is there, without any sensory issues, then thermal stimulation won't help much. Thermal stimulation is basically for the sensory. It's more of like hyposensitivity or hypersensitivity. If it's there, they generally balances it. That's for that thermal stimulation helps. Otherwise, not a big wonder happens with thermal stimulation.
Pratishmita, if the patient comes with your lack of sensitivity in the palate, there is velopharyngeal incompetency and regurgitation. How do you work with?
So first, that's the first thing where we start up with thermal stimulation and also sensitization of the palate.
There, cold thermal stimulation works very good.
Yes, sir. Cold also.
That cold thermal stimulation works very good.
Okay, sir. And then after that, we generally work with the soft palate, muscles of the soft palate, strengthening the muscles.
Yes. Then you can work with the velopharyngeal incompetency. Yes.
Okay. Fukan sir has asked dysphagia, stammering, dysarthria. How to differentiate? Prognosis.
Sir, dysphagia, of course, it's a problem in swallowing. Stammering.
No, dysphagia is SIA.
Dysphagia. Okay, aphasia. That is aphasia. Okay, dysphagia is mainly a problem of language. So they will have problem in the language. Whereas stammering is a problem of speech. Stammering is completely different thing. Like in stammering, they will have, it's a problem of the fluency of speech. The fluency of the speech will be affected. In dysarthria, it is the problem of the muscle weakness, and the speech will be fine. They will have a good fluency. I mean, they will have a normal fluency, not good fluency, but they will have a slurred speech, or they will have more of misarticulation, or they will have more of like unintelligible speech in dysarthria. And prognosis, yes. Prognosis, dysarthria generally has. If it depends, if it's the it depends on the extent of lesion for dysarthria. Stammering, again, the prognosis for stammering depends. If it's a neurological stammering, it's very difficult. The prognosis is not at all good. If it's psychogenic stammering, yes, the prognosis is very good. If it's just stammering, then it depends a lot on lot of factor of the person. In dysphagia, again, the prognosis depends on the site of lesion and the extent of lesion.
Okay. So are there any more questions? If anybody wants to ask anything? Another common condition that we see is after cerebrovascular accidents and a stroke, the patients come to us usually, to the clinicians, consultants that they cannot speak properly. So maybe a temporary or a permanent situation. So if we send for therapy, then how do you approach that patient?
Ma'am, that's actually, it depends. Like if the person is motorically fine, ma'am,
suppose the person is doing all other works now, but little bit of maybe paralysis might be there of at one half of body or something, but his voice is not so good, intelligible. It's not intelligible. He wants to say, but it's not that intelligible. So what kind of exercise do you advise on? How do we approach that patient?
Okay. Actually, what happens after stroke, there can be only what you have said, it sounds more of like the person has only dysarthria. His language is fine. He is able to speak. Yeah. So if the person is only with dysarthria, we'll have to see which all subsystems is affected severely. So if we find out, okay, these also generally in dysarthria, almost all the subsystems get affected. So again, that's the basic approach. How I just said, like we'll start up with the respiratory subsystem, then with the phonatory, then with the resonatory, then last we have to go with the articulatory subsystem. So that's there. And for those kind of patient, but oral this OPT, oral placement therapy also works better. Children with people with aphasia, like after stroke who gets dysarthria, for them OPT generally works. But for Parkinson's, OPT doesn't work much. In Parkinson's, we have to do that traditional dysarthric management approach, like working on all the subsystems.
Okay.
And of course, LSVT.
Sir?
LSVT, yes.
And of course, LSVT.
Okay. Another set of patients we encounter mostly are this tremor patients without any other cause. So is there any specific therapy for them to help them?
Tremors, actually, it's nothing specific is there, ma'am. If we see symptomatically, it's again trial and error methods only goes on a lot of time. With one of the tremor patient, I tried RVT. It reduced. Actually, it has helped for one of the person with tremor. That was the only person I found with tremor who actually, he has reduced also, and he was very consistent. Otherwise, half of the people are not consistent only.
Yes, for tremor, it's very difficult to explain to the patient also because there are no specific cause can be found. And suddenly person, I don't mean the other with Parkinsonism or other diseases, but in benign essential tremors, there are no cause. But the people are unsatisfied because suddenly the tremor is more when they speak and it's difficult.
Biswas sir can add to it, I guess. Biswas
yes,
sir for tremor patient.
Tremor is a very difficult patient.
Yes, I am just asking for everyone here because we encounter these patients now to ENT, so we also do not have any solution most of the time.
Vocal tremor, sometimes it works, if sometimes it doesn't work.
Yes, sir.
And even other tremor also, sometimes it works, if sometimes it doesn't work. Same traditional therapy as that of dysarthric patient. Same therapy keeps on going. Works on respiratory phonatory system or resonatory articulatory system. Some patient it works, some patient it doesn't work.
Okay. Okay. If counselor, can you add anything? Or anybody else, if anybody wants to add anything? Okay, then I'll ask Anjana ma'am to give his remarks. Give her remarks. Anjana ma'am.
Thank you so much, Devika.
Yeah.
I hope there is no other questions now in the chat box.
No, I have not seen. That is why I was asking if